And why don't we get started? Everyone, welcome to today's Cardiac College online session. The topic for today is, what is a heart attack? And this is me speaking to you again. My name is Paul O. I'm the medical director in the Cardiovascular Disease Prevention and Rehab program at the University Health Network. It's my pleasure to join you again for one of these sessions. A reminder about the ground rules that these sessions are designed for education. We'd ask you to please see your healthcare provider for more specific guidance about your own health situation. But we do love the Q&A parts of these encounters and would be happy to entertain questions. I may just choose to generalize the responses as to as opposed to getting into personal details. Let's leap back a little bit before we jump into what is a heart. What is a heart attack. Let's return a little bit to kind of foundational elements and kind of grounding the discussion into how does the heart work, and a reminder that we've got these different systems and anatomic structures in the heart. The heart itself is about the size of your fist and lies in the center to left part of your chest. It's got these lovely chambers, including the atria and the ventricle, that beat in sequence and in coordination. They are separated by valves to keep the chambers as distinct locations and blood flowing in the right direction. And it's got these blood vessels where the blood flows into. The muscle of the heart is also supplied by different systems so that it can actually function in its optimal way. We talked before about electrical systems and heartbeats that can go wrong. We've talked about valvular problems of things sticking or leaking. Today we're going to talk about the blood supply or the plumbing system of the heart. This is maybe the most common form of heart disease that affects individuals participating in our rehab program, and it may reflect your own personal situation as well. Diseases of the blood vessels are often characterized in this term, coronary artery disease, CAD, or may have a more general pathologic description of atherosclerosis or arterial sclerosis. But I think we're talking about some of these kind of common elements that may be represented here. There's occasionally people in our program that may come to us after a different kind of coronary artery disease issue, like a dissection. If there are specific questions about that, we'd be happy to entertain them in the Q&A. A reminder that coronary artery disease is something that it builds up over time. When we are young, very young, like in our teenage years, coronary arteries are nice and wide and open, represent a big tube where blood will flow in an unrestricted way. Past the age of 20 and serially over decades thereafter, we'll start to build up plaques in our artery walls. This is the fatty atherosclerosis substances that will build up, reach a critical point over time, and there may be cracks or ruptures that happen in those arteries that may lead to thrombosis. This more detailed diagram of the blood vessels on the surface of the heart are shown here. And some of you may be very familiar with these terms, where you've had specific blood vessels that have been affected. So if the heart is a muscle about the size of your fist that lies in the left part of your chest, if you look, and sometimes I represent that as like a fist. Pardon me. A fist, you can look at the back of your hand and look at the blood vessels that might be on the back of your hand. So that's very much like what your heart pump might look like and the blood vessel structures. The major blood vessels on the heart can be divided into the right side and the left-sided system. The right side is appropriately named the right coronary artery. And then the one on the left side is called the left main coronary artery, that then further divides into other branches, such as the circumflex, or the left anterior descending artery, the big one that comes down the front of the chest or the heart. And that's the one that we get most concerned about when it gets blocked off, because that supplies the major pumping chamber of the heart. Some of you may have had an experience of just one of these coronary arteries. Some of you may have had blockages in more than one of the vessels. Some of you may have had these treated by individual balloon, angioplasty, and stenting, while others might have had bypasses that were done to multiple blood vessels in the heart. And some of you may have been told that you've got less severe blockages in a few of these arteries that have been left alone, and that the best management for them might be living well, eating well, exercising, not smoking, taking medications, and doing all of these things. All of these approaches work hand in hand to keep all of these blood vessels kind of as healthy as possible. And you can kind of get the impression that there's lots of blood vessels that supply the whole wealth of muscle that makes up our heart. Okay. So if you want to see a little bit more of a kind of an animated video, I'm not going to show you that right now, but I'd invite you to go to that American Heart Association website, watchlearnlive.heart.org. And you can see some cartoons of what these blood vessels look like in the heart. But once again, we're trying to represent the normal coronary artery when we're young as this big open tube. And the wall of the arteries are comprised of these different layers called, in Latin terms, the adventitia, the media, which is sort of that muscular layer, and then the intima, the intimate part of the blood vessel, the inner lining. And when we're young and everything's working well, this is a beautiful, smooth system, and blood just flows down without any impediments. As time goes on, as we've said, in our 20s and 30s, we start to build up a little bit of fatty deposit in our arteries. You can see blood will still flow in a very unimpeded way. The blood is just going to keep going if there's only a little bit of kind of buildup in the walls of our artery. But you can, I think, all appreciate that this sets us up for future bad things that are going to go on in the arteries. And later on in time, for most people, there is variation, and some people get to this at a younger age compared to others. But when there is enough plaque that is built up in the arteries, there may be some restriction of blood flow, but there's also instability in these plaques, and they may be labeled as, quote, vulnerable or friable. I imagine it like it's the volcano that's getting ready to erupt. And not that I want to scare anybody, but it's an interesting way of thinking of what's going on pathologically within these arteries. When these plaques build up, they may be unstable, or some of them may actually, if they grow slowly enough and are mostly fibrous in nature, they may be quite stable. The problem with stable plaques is that they kind of block the blood flow, but it's the vulnerable or unstable ones that may be more prone to rupturing and leading to heart attacks over time. And that's what's shown here in terms of a rupture of a plaque. And these things may happen spontaneously on their own. Sometimes they may be triggered by an event that we may recognize. And some of you may have had that experience, that you're fine until something happened. It might have been a physical stressor like shoveling snow, or engaging in vigorous physical activity. It might have been associated with a mental stress, or a social stress where these sorts of things happened. It might have been associated with some other kind of noxious exposure, like smoking a cigarette can cause all of these sorts of things to happen. But plaque, if it's unstable, can be prone to rupture, and then thrombosis, a blood clot may form at the site of that rupture to start with, that will grow and grow further, and they may actually block off blood flow entirely, so-called occlusion of this blood vessel. This is what is represented as a heart attack. That there is complete blockade of blood flow, no blood or blood cells are traveling here. There's no delivery of oxygen further down this blood vessel to the heart muscle, and the muscle becomes compromised and may actually die off in parts of it. So if the clot completely blocks the coronary artery, all muscle tissue below that blockage can die. And that's what's shown here, that if this section of the left anterior descending artery, as the example, becomes blocked off entirely, then the area of muscle that is fed by that artery can become compromised or even die, unfortunately, as a result. If this is going on, this may be all too familiar for some of you, and you may have had that experience of the heart attack. So if we imagine that there is blood flow restriction and there's damage to that heart area of heart muscle, we may experience this as classically the chest discomfort or pressure or heaviness in the center or left part of our chest that may radiate down our arm or up into our neck or our jaw. It may also be perceived in the back. Not everybody feels this, but that is the kind of classic symptomatology. And the Heart and Stroke Foundation of Canada created this infographic for us, or for everybody, that describes these myriad of symptoms that more classically is the chest discomfort, maybe accompanied by sweating, maybe upper body discomfort, may also be associated with nausea, because there are these shared sort of nerve pathways between the heart and pain and nausea receptors in the brain. Some people may experience shortness of breath with everything else, or some people just may have shortness of breath without anything else. That some people don't experience pain or discomfort, but only perceive this as, I am feeling breathless. Some people may feel lightheaded because of impairments of blood flow or other bad things going on in the heart. It may manifest as lightheadedness with impaired blood flow up to the brain. There is a difference by sex and perhaps by gender, but heart attacks in men have this classic description of that chest discomfort with radiation to the jaw or the arm, nausea and shortness of breath if there's a heart attack going on. But in women, women may have a different characteristic group of symptomatology, and more often women compared to men will not experience chest discomfort. Sometimes it is only discomfort in the upper back, or a feeling of that lightheadedness or actually passing out. Something that may feel more like indigestion or tiredness. Someone I saw this morning who was a younger woman was very characteristic of this symptom set instead of the chest discomfort. When there's confusion or lack of clarity about what's going on, it may lead to delays. I'm not saying that this is anybody's fault, but it's just that we need to all become more aware of the differences in presentation, so that if we have that heartburn that just doesn't go away for women and for men, that's quite unusual in nature, that actually could be a sign that there's something going on with our hearts. So let's seek out attention if there is something going, if we feel like there's something just not right. And that applies equally in this time of COVID as well as times without COVID. What my colleagues say to me that are working in the emergency department or the coronary care unit or in surgery is that one of the unfortunate kind of byproducts of COVID is that people have been avoiding going to the hospital because of fears about COVID in the hospital sort of setting, to the detriment of the heart. So we'd ask you not to do that. If you're feeling unwell, get to hospital. They'll look after you. If you have COVID, they'll look after you. If you don't have COVID, and heart disease still remains a priority when you get to the hospital. This graphic from the American Heart Association, once again, kind of highlights the differences between men versus women. There are many things that are the same, but there are some things that are different, as we've pointed out, perhaps less chest discomfort and having discomforts elsewhere in the body, or the fainting, or the indigestion, or just really feeling tired out. So all of us, let's be aware of that. Women in particular, we're inviting you to be even more attuned to all of these things. And on the healthcare practitioner side, we'll do our best to be more aware of this as well. If you do get to the hospital, they may do some tests to help confirm if in fact that there is actually a heart attack going on. And blood tests can sometimes help with this. If there is damage to heart muscle and some of those cells in the heart muscle actually break down, they may release substances into the bloodstream that can actually be picked up on a blood test. If we draw one out of your arm, we can look for measurement of substances that go higher as a signal that the heart muscle has actually been damaged. The modern test for this is a test called troponin. Troponins are a group of proteins that are found in the heart muscle fibers. Normally, they're responsible for helping with muscle contraction, but if those fibers and cells have broken down, then this troponin substance leaks into the bloodstream. Normally, troponin is present in only very small or undetectable quantities in the blood, but when there is damage to heart muscle, troponin is released. You will imagine that if there is a larger amount of damage to blood, to the heart muscle cells, there's going to be even higher levels of troponin that can be detected. It takes a few hours for troponin to become measurable in the bloodstream. So if you are seen immediately in the emergency department and they measure your blood, the levels may not be particularly elevated. This is why they will do tests again after a few hours, and then maybe even again a few hours after that, to see if there is this detectable rise in the level of troponin over time. Once the levels go up, it may take several days for the levels to go back down again, completely back to normal. And if we've got other kinds of health issues like kidney problems, where filtering of the blood is a little bit impaired, the troponin levels may stay high for some period of time, or they may always be a little bit high. So good news here is that there is confirmatory blood tests that can help us with the diagnosis if there is some confusion about this. There are also other tests that can help us describe or to tell us what's going on in the heart. And I think everyone on this call would have been familiar with the electrocardiogram or the ECG. We did discuss this in the context of abnormal heart rhythms, but it is also one of the important tools that we use in the setting of heart attacks to try to tell us if something dangerous is going on. The electrocardiogram is a tracing of the electrical activity in the heart. And the 12-lead electrocardiogram that you've all had done in hospital or with your primary care practitioner is a 12 different camera angles of the electrical activity that goes on. There was this guy named Eindhoven in Germany that sort of came up with the whole design of the electrocardiogram, and he was the one that gave it some of these names. So they may not be all that intuitive, and you know, when we have students and other trainees, we try to get them to learn some of the just kind of the rote stuff that is part of the electrocardiogram. So 12 different leads, and they're called leads 1, 2, and 3 as different angles of the left arm, the right arm, and then kind of leg angles of the electrocardiogram, ones that point at the shoulders as well as right down to the groin. And then V1, 2, 3, 4, 5, 6 are different angles going from the right side of the heart to the left side of the heart. So just like a complex film where there might be all these different camera angles, or sport, we can do the same thing by looking at different electrical angles of the heart. What it tells us is that it tries to localize certain areas of damage to the heart that then might give us a clue to which blood vessels of the heart might be involved in the setting of a heart attack. We look at the shape and the composition of the electrical signal, and this is a blown up picture of what a normal electrocardiogram beat looks like on a regular ECG. It has these different waves associated with it. A P wave that is associated with the electrical impulse starting in the upper right chamber of the heart and then traveling downwards from upper right to lower left. So P wave corresponds to electrical activity in the upper atrium. Then QRS denotes the electrical activity as it travels through the main pumping chamber, the ventricles. And then there is a T wave where the whole system gets reset. And then it starts all over again with the PQRST. PQRST, there is a nice regular pattern to this. When there is abnormality of the blood flow in the heart and there's damage, we look in particularly in this segment here, between the S wave and the T wave, for changes of the ST segment to tell us that there might be a heart attack going on. So here is a normal electrocardiogram. And then here, I think you will appreciate with me that there's the P wave, QRS complex is here, but then there's the ST wave that is way up in the air compared to here where it's at baseline. So these segments here, where the ST segments are pushed way up, corresponds very characteristically to damage going on in the heart. This is what we look for characteristically in the setting of a heart attack. So if we look at a 12-lead electrocardiogram of this going on, here we're seeing where these red arrows are denoted, marked elevations of the ST segment here. Instead of being at baseline right here, it is up in the air, about 6 or 7 small boxes or 6 or 7 millimeters. This is a strong clue that the artery on the front of the heart, because these are the camera angles of the front of the heart, there's a major blockage, or if we discover that the left anterior descending artery was blocked, this is what an electrocardiogram looks like. The other things that happen during the setting of a heart attack, maybe some other irregularity in the heartbeats, because you can imagine that if you restrict the blood flow to a segment of the heart, if there isn't enough oxygen to supply that muscle, it becomes rather irritable. Just like if you overuse a muscle, it might start to cramp and seize on you. The heart muscle kind of does the same thing electrically, and it may show up with these funny looking beats. Here you can see there's once again in the upper strip here, this is what a normal segment of an electrocardiogram looks like. Here we're seeing a pretty normal beat followed by a very unusual beat. This is a early one. It's wide, so it's coming from the ventricle. It's early, so it's called premature. Ventricular premature beat is what's given to this name. So these often are accompanying beats in the setting of a heart attack. We need to watch for them. Sometimes we can offer up some medications to try to calm these down, but they are a signal that we need to watch very carefully. And this is why if you end up in hospital in the coronary intensive care unit or on the cardiology ward, that they may put on the electrical telemetry pack on your chest to watch your heartbeats on a regular basis to assess for these kinds of irregular heartbeats. This is one that is even more scary that may be seen during a heart attack, you can appreciate that instead of this nice regular system that's seen up here with the P QRS T wave, P QRS T wave, that's normal. This is very wide, it's very fast, it's very bizarre looking. It almost looks like the teeth of a shark. This is called ventricular tachycardia. You can think of it as that dangerous. And occasionally this is what happens during a heart attack that may be associated with stoppage of heart activity or a heart cardiac arrest that may happen. You recall that when we did our arrhythmia session together, that the lack of coronary artery blood flow that deprives oxygen to heart tissue may be the cause of this ventricular tachycardia. So if this is going on, the heart attack or narrowing of blood vessels, what can we do about it? Well, we've talked about this before, that one of the approaches that can be done directly at the time of the heart attack, if you get to one of these big heart centers in whichever city that you're watching us from, then they can take you right up to the angiogram room, take a picture of the artery. If they figure out there's a blockage there, thread like at this segment, thread that wire down the angioplasty catheter that has a balloon and a stent associated with it. And then the stent can be expanded. And then this blockage is now opened up very, very nicely and blood flow can be restored. This would be called a primary angioplasty treatment of a heart attack. So it's the main intervention that is done, which is great. And on the angiogram, what we might see, this represents the right-sided artery of the heart, the right coronary artery. The cardiologist may see that there was a narrowing in that segment of the coronary artery and that there was damage to the heart muscle down below. What they can do with the angioplasty catheter and the balloon and the stent is open this up beautifully and restore blood flow and hopefully rescue some of that damaged muscle where at all possible, which is really nice. The other thing that can be done, and I'm sure some of you might have wondered about this, is that if you're not in a place where they can do these primary angioplasties, there are still ways of trying to save as much of the heart muscle as possible. And over the last, 25 years, there have been terrific developments of medicines that can actually break down blood clots as well. We call this thrombolytic therapy. Thrombo refers to the blood clot. Lysis or lytic therapy is breakdown. So breakdown clot or clot busters. And some of you may have been familiar with this as kind of the liquid Drano, to refer to the plumbing product approach to opening up blood vessels. So there's a number of different formulations of this medication, alteplase, retaplase, tenecteplase, streptokinase, these kinds of medicines that are injected into the vein, circulate around for 30 or 60 minutes and actually break down these blood clots in the heart. And then we can follow them up with other medicines that we know thin the blood. You're very familiar with these medicines from our sessions together around medications. If you haven't heard it before, we'll talk about it next week. Aspirin and other kinds of blood thinners to keep the blood flowing. And, in the Southern Ontario context, if you land in your hospital up in cottage country, for instance, terrific physicians, terrific emergency departments, but they tend not to have primary angioplasty available, they may choose to give you one of these medications to break open that blood clot and then arrange for emergency transfer down to a hospital where they might be able to do the angiogram and put in a balloon and a stent. In colloquial terms, we call this the drip and ship therapeutic approach. The drip refers to giving one of these medications and blood thinners, ship you down to another center where we can do an angioplasty and stenting procedure as well. So taking advantage of both of these things might be very useful for some individuals. Okay, So we've covered a fair bit of territory today, ranging from the normal anatomy to the development of clots or to narrowings, to interventions that we can do for them, the diagnostic tests from blood tests to ECG that can be done as well. So now is the time where we would love to entertain some questions. And I see that there is one in the chat box, a terrific question about, great question about, can the heart regenerate damaged muscle? And the answer today is kind of a mixed one, where there's a yes and a no. On the one hand, if heart muscle has been severely damaged for a prolonged period of time, unfortunately, it's very hard to bring that back. And the tendency is for severely damaged muscle to then transform into scar tissue over the next several days to weeks. And that's unfortunately what will happen to some of us who've experienced a major heart attack. For some people, it may be that the heart is damaged, but it hasn't actually died in the setting of the heart attack. You can imagine that it may be kind of gone to sleep. We actually use that term of hibernating myocardium or hibernating heart. Imagine it's like the bear that goes to sleep for the winter, but then is able to wake up again. So for some people, if there is narrowing of blood vessels and impairment of blood flow, some of the downstream muscle may just go to sleep. When the blood flow is restored, then that muscle may wake up again. So it's not really regenerating the muscle, but it is waking up the muscle that's been kind of in a state of sleep or stasis. There is, those are two concepts. Damaged muscle may be permanent. There is some muscle that is damaged that can wake up. A third very exciting concept that that is continually being explored, and there's advances year over year, are interventions to try to grow new muscle using stem cell technologies. And I don't think we're quite ready for prime time, so to speak, yet, but there are amazing researchers, and Toronto is one center where this is going on, where kind of the early, like the primitive or the originator cells for heart muscle cells can be injected into the heart muscle area that's been damaged. That can be done directly, like at the time of surgery. It can be injected into the vein and then carried around, and they will hopefully localize at the site of the muscle, and then regrow the heart muscle as well. So we're not quite there yet, but hopefully we're getting closer. And then there are also some therapies that can encourage blood vessel growth. There are these growth factors that can be also injected. So the best approaches to doing this are still being worked out. It's very exciting, but we may get to a time where there may be some heart muscle that can be regrown for many people. Let's hold. Let's kind of look forward to where that might come forward as an exciting new therapy. Another question is about that blood test or the troponins. What signifies a minor or major heart attack? And as we said, for most people, if all of our body systems are working well and our hearts are functioning well, then we really don't measure any troponin in our blood to a significant degree. If there is a little bit of damage to the heart, then we'll go up into the tens of troponin. So say between 5 and 100 would signify some smaller amount of damage. But then if there's bigger damage done to the heart, then we'll go up into the hundreds. And those are rough ways of kind of characterizing how much heart damage might be done. The other thing that we will do to kind of quantify damage from the heart is try to take some pictures. And typically, you may have something like an echocardiogram or an ultrasound done after you've had a heart attack to look at how well the walls of the heart are moving. Once again, if there has been damage to a blood vessel that then has led to damage of the heart muscle, we look for evidence of how well that heart muscle actually is able to contract or not. The scenario I think that we're creating is that if you've gone in with chest pain, you've done a blood test that shows that the troponin levels have gone into the hundreds. If the electrocardiogram is showing a lot of damage, like shifting in those ST segments, and then you do an echo picture that looks like that heart muscle isn't just moving anymore, it's just kind of stuck, then all of that would come together to say, this looks like this was a pretty major heart attack. Okay, well, thank you for those questions. I don't see anything else coming up, so let me just move on then to kind of round out this session and invite you to join us again on next Monday at 10 o'clock in the morning. I'll be doing that session again. We'll talk further in detail about the various kinds of heart medicines that we might be taking. Hopefully you'll be able to join us for that session. If you can't, you'll find that these sessions are recorded and available on the Healthy University website. So please do join us. Otherwise, thank you very much for connecting in today. And we're wishing you a very heart healthy day as we get into our spring. Take care and good health to all of you.